requires a first name. So he goes by Ambal, much like Bono. And he will be talking today about BPD phenotypes and endotypes. He hails from the University of Alabama in Birmingham, where he's professor of pediatrics. He's also the co-division director of neonatology, as well as the fellowship director there. He's the director of many more things, of neonatal research, of translational research in normal and distorted development, which has the clever acronym of TREND. He's also the center PI for the NICHD Neonatal Research Network. He's a physician scientist and a renowned, phenomenal expert in neonatal lung physiology. So with that, I will hand it over to Ambal.
Thank you, Clara, and thank you, Mariel, for inviting me. It's great to be with you all. So today we are going to be talking about BPD. And let's see. So here are some disclosures, nothing you need to be concerned about. And obviously, this is evidence-based as much as we can make it. So the objectives today are to recognize heterogeneity in the pathology of BPD and differentiate different phenotypes and endotypes of BPD, just recognizing that all BPD is not the same. And also to determine the role of biomarkers in predicting BPD and the potential role of new therapeutic strategies. So what exactly is BPD? That's something we all try to diagnose in our preterm babies, generally when they are stuck on the ventilator or need oxygen beyond 36 weeks postmenstrual age. But that's a kind of a circular definition because it's defined by oxygen administration at 36 weeks, and it doesn't specify what exactly is wrong with the lung at that time point. So it's a diagnosis that is defined by its treatment. It's like saying anybody who gets antibiotics has sepsis, or anybody who is exposed to methotrexate has cancer. So that's a very poor definition. And we all know the different variations in BPD severity, mild, moderate, and severe, and also the so-called classic or the new BPD in terms of pathophysiology. So infants with BPD exist along a continuum with varying combinations of clinical and pathologic features. Infants are very different in terms of what exactly their lung physiology and pathology is like. So this is an example of an infant with BPD, an X-ray from one of my recent patients, and this shows what you would consider as the classic parenchymal injury, where you have patchy areas of atelectasis in the lung. Remember that it could be a combination of the fibrosis, inflammation, inhibition of alveolar development, and so forth within this, with varying degrees of severity. This is a different infant who also has BPD, but this infant is one with pulmonary hypertension. It's a 3-month-old X24-week, 600 grams at birth, who developed suprasystemic pulmonary hypertension with the right ventricular pressures of more than 80 and a B-type natriuretic peptide of more than 3000. So this infant has a vascular phenotype. But again, when we say vascular phenotype, it doesn't specify one specific etiology. It could be pulmonary vein stenosis, it could be collaterals, it could be vascular remodeling. So it could be multiple different etiologies of the vascular phenotype. This is a third infant who was also 3 months old, X22-weeker, 400 grams at birth, who kept failing extubation multiple times. And finally, we did a chest CT with 3D reconstruction, and you can see the marked narrowing of the left mainstem bronchus. And this infant also had persistent left-sided atelectasis subsequent to that. So this is an example of the airway phenotype. So again, you may have tracheobronchomalacia, you could have small airway disease, or varying combinations of that as part of the airway phenotype. And this is a 3-month-old who is still in the hospital, actually. Now he's a bit older, ex-22-week, 500-gram infant who has frequent desaturations and apnea requiring ventilator support. You can see the frequent desaturations above. And this is an infant who has abnormal control of breathing. So we have looked at infants who have parenchymal lung disease, who have had the vascular phenotype, who have had the airway phenotype, and abnormal control of breathing. Now, most preterm infants with BPD have a varying combination of all these endotypes. So it's not that they have just one. They may have more of one and less of the other. Let me just go back. So why does this matter? Phenotypes matter because the response to the treatment we use varies by phenotype. So Ed Shepard, one of my collaborators from Nationwide, he has done work on pulmonary function tests using the Inspire, in which infants are intubated, sedated, and then they compress the chest rapidly and do spirometry that way. So these infants were all done at mean postmenstrual age of 52 weeks, so 3 months corrected age. And of these infants with BPD, 51% had an obstructive phenotype, that is more of an airway phenotype, and 3/4 of them had a bronchodilator response. 40% had a mixed phenotype, that is obstructive and restrictive, and about 2/3 of them had a bronchodilator response. And some of them had a purely restrictive phenotype, and only 25% of them had a bronchodilator response. Therefore, if you have the airway phenotype or an obstructive phenotype, you're far more likely to respond to bronchodilators, whereas if you have a restrictive phenotype, you're less likely. So these operational definitions, that is labeling an infant as BPD, doesn't capture the phenotypic or the genetic heterogeneity underlying pathogenesis. The way I think of it is all normal lungs are similar, but every abnormal lung is abnormal in its own way. There's a varying combination of parenchymal, vascular, airway, and control of breathing abnormality. And I'm going to talk to you a little bit later about biomarkers. And the biomarkers changes are associated with the type of lung disease that these infants have. So this is a good way of looking at lung disease. It's the wheel and spoke model, or sometimes you can think of it like a pizza. So for example, the upper left quadrant is parenchymal lung disease, emphysema, disrupted vascular development, and so forth. Those are the structural traits. Whereas the top right quadrant is the physiological traits. That is there physiologic airway obstruction? Is there pulmonary hypertension? Is there impaired gas transfer, and so forth? And the bottom right is clinical traits, such as is there sleep disordered breathing? Is there respiratory failure? Is there wheezing? Is there cough, and so forth? And the bottom left is inflammatory traits. That is it eosinophilic inflammation or neutrophilic inflammation or T cell inflammation? So all these things could be present in the same infant, but the extent of their involvement would vary by the infant and also over time in the same infant. So it's not like the infant would have just one phenotype which persists for the rest of the hospital course. You could transition from one type to another. So how do we go about reducing BPD? So far, what we have tried to do is the standard approach where we do the QI method, which is identifying the potentially better practices or best practices based on the review of the available evidence. And then you try to implement these PBPs using QI methods. So you try to implement the best practice and hope that your outcomes are better. In the future, we are probably going to identify more specifically what exactly is wrong with the lungs of a specific infant and treat it. We need targeted interventions for individual infants, that is personalized medicine, based not just on clinical assessment, but also based on statistical modeling and biomarkers. So what are the standard approaches that we have tried? Obviously, antenatal steroids, and we all know about the emphasis on using more CPAP, adjusting gas exchange, similar to what was done in support and COT and boost and all those other trials. That is 91 to 95. Avoid mechanical ventilation as much as possible. And surfactant therapy, now we use all these minimally invasive methods. And there is some interest in giving it with budesonide. For example, the Dr. A from Taiwan has done some trials on that, and Brett Manley and others from Australia have done the PlusS trial. I'm doing the BIB trial, the Neonatal Research Network. So there are multiple trials going on with that. And we all know the importance of fluid and nutrition management, restricting fluid intake, improving nutrition, especially protein intake, and multiple medications. The ones which have been proven to reduce BPD are caffeine and vitamin A. Steroids, again, they do reduce BPD, but again, it's not universal. You've got to use them carefully. Antimicrobial use, again, based on the situation. And diuretics, people use them, but again, do they really work? What's the long-term effect? We don't know. So this was what we learned in medical school in the 1980s, or about 40, 50 years ago. And this was simple. We had DNA, which led to the formation of messenger RNA, and then to the formation of protein. So that's quite simple, easy to remember. But now we know that it's actually a lot more complex than that. We have all these different omics. We have the genomic effects, and then the transcriptomic effects, and the proteomic effects, and the epigenomic. That is, DNA can be methylated, and then there's microRNA, which can also affect splicing. And then there is the microbiome, which also affects all these different variables, and the metabolome. And the metabolome could be either from human cells, or from the microbiome, or from the medications that we take. So all these lead to multiple levels at which the lung development is controlled. That is, it's not just at the level of the gene, but at transcriptomic, epigenomic, proteomic, microbiomic, and metabolomic levels. And if anything goes wrong with any of these steps, then we have abnormal function. So when I'm going to talk about biomarkers, remember that these biomarkers could be organelle specific. We are going to talk a little bit about mitochondria. It could be cell type specific. Again, we are going to talk a little bit about endothelium and cell-cell interactions. We're going to briefly mention exosomes, which are small extracellular vesicles, which one cell releases and another cell picks up. So these biomarkers can help in prognosis, they can help in guiding therapy, and also in identifying mechanisms. So over the next half an hour or 40 minutes, I'm just going to briefly go over some of our research on all these topics. So I'm not going to go too much into the basic science aspects because I realize most of you are clinicians. So this is going to be more of a clinical and translational talk. So we're going to talk a little bit about the genomics, the microbiome, the microRNA, mitochondrial function, cardiorespiratory signal analysis, and lung mechanics. So first, what's a biomarker? So a biomarker is a characteristic that is measured and evaluated as an indicator of normal biology, pathogenic process, or pharmacologic responses to a therapeutic intervention. So it's not just indicator of pathology, it could also be a marker of normal development or how we are responding to a treatment. So that's why biomarkers are useful, because they could be used to look at all these things. And they can be a clinical feature, could be a radiologic feature, or a laboratory-based test marker. So it's not necessarily something sophisticated. You have to do a sophisticated or fancy test. It could be a clinical variable too. And as I mentioned, there are these different endotypes: parenchymal, vascular, airway, and control of breathing. So each of them will have different biomarkers. And it depends on what's the source of the biomarker you're looking at. For example, if you're doing bronchoalveolar lavage or tracheal aspirates, it's going to be different than the signature you're seeing in the plasma or what you're seeing in the urine. And it also depends on whether you're looking at mRNA or protein, because sometimes they're not concordant. Only about 1/3 of the time are they concordant. postnatal age, gestational age, and the endotype. So as I mentioned, there are many biomarkers, clinical variables such as birth weight, gestational age, and respiratory support alone would explain a lot of your risk of BPD. I think probably 80 to 85% of your probability of BPD you can predict based just on birth weight and respiratory support magnitude. But then you can also look at various inflammatory mediators in the blood, tracheal aspirates, exhaled breath, lung mechanics, urinary biomarkers, or the imaging. You look at the chest X-ray and you see multiple patchy areas of atelectasis and large cysts, you know that baby has severe BPD. Echocardiogram.
I hate to interrupt, Ambal, but it seems like you're frozen for me. Is anybody else seeing him?
Yeah, we lost the feed, both audio and video for him.
Oh, okay. Let me send him a quick message. So folks, I haven't heard back from him yet, but I'll give you an update if we could just maybe give him a few minutes and see if he's trying to reconnect. Oh, there he is. There you are. We missed you. Oh, now, oh, it seems like you're muted, Ambal.
Oh, sorry. Where did I drop off?
Let's see. I think you were at, would you pull up the slide that you think you're
Yes,
at?
let me see. Yeah. Yeah, I didn't realize I had dropped off. So let me see. Can you see it now?
Yes, I think we're back at least one or two.
There's a figure of a baby, outline of a baby.
Yeah,
That one.
okay,
go.
this one. This one?
Yep.
Okay, perfect. Okay, let me go back. So, I mean, these are some of the biomarkers that we usually look at, but obviously, the clinical variables are the ones which are most predictive. Just the birth weight, gestational age, and respiratory support alone will explain about 85% of your risk for BPD. There's also various pro-inflammatory cytokines and other biomarkers we can measure in the lung and blood. Also in the exhaled breath, the lung mechanics, and X-ray imaging too. Obviously, if you look at an X-ray and you see multiple patchy areas of atelectasis and cystic areas, you know the infant has severe BPD. Echocardiogram could show you pulmonary hypertension or other markers of bad lung disease. So those are some of the things that we look at in terms of routine clinical practice. Now let's go on to the genomics. So the important message I want to tell you is that severe and moderate BPD are different, very different from the genetic perspective. So this was a genomic analysis of BPD that we did in the Neonatal Research Network. And this is the pathway analysis. So there are different pathways which are associated with BPD. And the ones on the left here are the ones associated with moderate to severe BPD. And on the right here with severe BPD or death. And you can see that they really don't overlap. So the infant who is stuck on a ventilator at high settings at 36 weeks is very different from one who is just on a little bit of oxygen by a cannula at 36 weeks. So moderate and severe BPD have a very different genetic basis. We've also done microbiome analysis. That is, we have collected the tracheal aspirates at the time of birth or very soon after birth, so before they actually become colonized. And we found that even at the time of birth, preterm babies have a lot of microbial DNA in their tracheal aspirates. So I'm not saying they're a live bacteria, but there is microbial DNA, which probably comes across the placenta from the mother. We have looked at the placenta from first trimester pregnancy and second trimester pregnancy between 11 and 13 weeks of gestation and find a microbial DNA even at that time point. So there's a lot of microbial DNA coming across the placenta. And we found that lactobacillus DNA is decreased in the infants who later develop BPD. So this is looking at the microbial DNA at the time of birth, and we can actually predict which infants are going to develop BPD many weeks later. So if this is a 23-weeker, we are predicting outcomes at 36 weeks. That is about 4 months later, 3 to 4 months later. This is in a discovery cohort at UAB, and the validation cohort was from Philadelphia. So we looked at 2 different centers because we want to validate the data from a different center. We also looked at exosomal microRNA. So exosomes are very tiny particles. They are about 20 to 200 nanometers in size, and they are like little blebs of lipids which contain cargoes such as microRNA or mRNA or peptides. So we looked at exosomal microRNA again from these tracheal aspirates at the time of birth, and in our discovery cohort we found 40 different microRNA. And of those 40, we found 6 were different, even in the validation cohort. So we looked at the top target, which was this MIR876-3P, and we found it's a very strong predictor of death of BPD, an area under the curve of 0.92, which indicates a very good biomarker. So we also showed that this microRNA is regulated both by bacterial LPS as well as by high oxygen concentrations. And if you block this microRNA in a mouse model, you can improve lung development. So it may actually be important in the pathophysiology. Then one of our other faculty, Dr. Jagan Kandasamy, he has taken an innovative approach to look at mitochondrial function. So obviously, babies are born with an umbilical cord. So we take a small piece of the umbilical cord from the either from the baby end or from the placental end, and then we flush out the umbilical vein with dilute trypsin, and we collect the endothelial cells. So those are called HUVEC, or human umbilical vein endothelial cells. And then we culture them, and then we put them in a dish, and we subject them to bioenergetic analysis. So these open circles and red line is the infants without BPD or death, and the dark circles and blue line are the ones who die or develop BPD. And you can see there's a lot of difference between the basal as well as the maximal oxygen consumption rate between the endothelial cells from the babies who die or develop BPD and the ones who don't. So remember, these are endothelial cells collected from the umbilical cord. So this is at the time of birth. So even at the time of birth, you can predict which infant is subsequently going to develop BPD or die many months later. And if you look at the mitochondrial DNA damage, again, it's a huge difference. So the infants who later go on to develop BPD have much more mitochondrial DNA damage. And actually, if you measure this oxygen consumption rate, it's a better predictor of BPD or death compared to gestational age or birth weight. As I mentioned earlier, gestational age or birth weight is a strong predictor, but the mitochondrial function is actually an even better predictor. And it's not just the endothelial cells from the cord. We actually were able to isolate MSC, that is the mesenchymal stem cells. We are able to isolate them from the cord. And even those are defective. And again, they're defective because their mitochondria don't work well. So, there's a lot of interest in using mesenchymal stem cells to fix the lungs for babies with HIE or for babies with BPD or for neck and so forth. Well, the problem is in many of these infants, the mesenchymal stem cells are not working well. So if you try to do an autologous MSC, they may not work very well. So what's the answer? Can you fix these MSC? Now the answer is yes, we can fix the MSC. We actually showed that thyroid hormone modulates this mitochondrial function, and it's also a regulator of hyperoxic lung injury and mitochondrial function. So the top panels are for human samples and the bottom for mouse. So at least in this regard, mice are quite similar to human. So this is looking at the thyroid hormone levels that we got from the newborn screening. So remember that all babies get newborn screening, including our preterm babies. So we looked at T4, TSH, and so forth in a few hundred babies. So the black ones, the black dots are the ones with moderate or severe BPD, and the red ones are the ones without. So you can see that the thyroid hormone levels are lower in infants who later develop BPD. And we also looked at other things in mice, which showed that PGC1 alpha is different. And if you give them thyroid hormone,
I'll let him know that it's probably happening again. Okay, folks, thanks for standing by. Ambal is repeating again.
yes, I'm back again. Yeah, I don't know why that keeps happening. For some reason, Microsoft Teams doesn't seem to like me very much.
It's well, yeah, it's a little picky.
Yeah,
We have learned.
yeah. Was I on this slide?
Yes.
Okay, perfect. Okay, so let's move on. So basically, if you want to put all these things together, it suggests that there is some unifying pathways. For example, corium neonitis leads to abnormal microbiome, which also leads to mitochondrial dysfunction. And these also are associated with increased exosomal release of specific microRNA, which affect different cellular pathways, and all that result in BPD. So not only are they biomarkers, but they're potentially involved in the pathophysiology too. So now let's shift gears a little bit to cardiorespiratory data. So this is part of the data from the PREVENT study, which was a multi-center study done by the NHLBI, and UAB was one of the centers, other centers being Case Western, Miami, WashU, and UVA was a data center. So we all know that preterm infants have immature control of breathing, which leads to intermittent hypoxemia, apnea, bradycardia, and periodic breathing. But we don't really know if all these abnormalities are associated with respiratory outcomes. That is, yeah, babies have apnea, bradycardia, but how is that associated with respiratory outcomes, such as BPD or longer term outcomes? So our objective was to determine the physiologic data can predict unfavorable outcome. And we spent a month or two trying to come up with what's the best outcome. As you mentioned earlier, BPD is not such a great outcome, but we came up with an outcome which is a lot like BPD, but at 40 weeks. So basically, unfavorable outcome was if the infant had died by 40 weeks or was still an inpatient on medications, oxygen, or respiratory support at 40 weeks, or discharged prior to 40 weeks on medications, oxygen, or support. And a favorable outcome was if they did not die or need any of these medications or support at 40 weeks. So similar to BPD, but at 40 weeks. And then we looked at these different time points, 7 days of age, 14 days, 28 days, and 32 weeks. And then we collected cardiorespiratory data, that is all the monitor data, heart rate, respiratory rate, pulse ox data from the cardiac and pulse ox data. We downloaded them, and then we did mathematical analysis on the models. And then we developed predictive models using the mathematical data. So what exactly did we analyze from the heart rate, respiratory data? So this is continuous data. So every second we had data on all the hundreds of babies. So we collected data on apnea, defined as more than 20 seconds, periodic breathing, intermittent hypoxemia, bradycardia. And for each of these features, we looked at frequency, that is how many episodes they had per day, the duration, that's the average duration of each episode, and finally the cumulative burden, that's the total number of amount of time per day with events. And this is the data. So we had a total of 700 infants, of whom 54% had a favorable outcome and unfavorable 46. Birth weight, you can see the ones with the better outcome had a larger birth weight and were slightly more mature. And obviously there's difference in intubation and so forth. If you look at the physiologic models, there is an improvement over time. That is, as the infant becomes more mature, your physiologic data are better at predicting outcomes. And which variables are most important? It turns out it is not apnea, it is not bradycardia, it's not periodic breathing, it's primarily intermittent hypoxemia. So at all the different time points, the duration per day and the duration per event of intermittent hypoxemia, less than 90% saturation, was the major predictor of respiratory outcome. And if you look at how it is distributed, so the blue line are the infants with favorable outcome. The brown one is mildly unfavorable, that is just on cannula or only medications at 40 weeks. And the yellow-orange one is moderately or highly unfavorable at 40 weeks. So you can see this is looking at a week of life, and the right graph is postmenstrual age. So you can see after about 26 weeks postmenstrual age or soon after birth, they start diverging, meaning that even as early as a couple of weeks after birth, you can actually predict which infants are going to have a bad outcome by looking at the duration of episodes and how long they have them per day. So physiologic data can predict unfavorable outcome, with accuracy improving with advancing postnatal age. The physiologic data variables that contribute most to prediction are intermittent hypoxemia less than 90, duration per episode, and total daily duration. So it's not so much apnea and bradycardia, it's the desaturation which is important. Now moving on to lung mechanics. So this is Colin Travers, that you see his picture down the right bottom. He's one of our faculty who has a K23, focused primarily on measuring lung mechanics in preterm infants. So for the past few years, we've been using this device called the tremor flow, which is an airwave oscillometry device. So it puts a random waveform to the baby who's spontaneously breathing. So you have a mask here, and you put that mask over a baby's mouth, and you put a waveform for about 8 seconds. And then you take off the mask, and then you put the mask on again for 8 seconds, and you measure it. So this measures reactance and resistance throughout the respiratory system. And it can be done in any spontaneously breathing infant who's not vigorously fighting you while you put the mask on. So most babies, we can do this pretty easily until about 6 months of age. So this was a paper we published a while ago looking at preterm versus term infants. The triangles are the preterm infants and the squares or the term infants, you can see that preterm infants have a higher resistance and a lower reactance at all the different frequencies. So this is just a small sample size, but now Dr. Travers has done more than 500 infants, many of them term infants, preterm infants without RDS, preterm infants with RDS. And he's going to be presenting this data at the PAS. So if you're going to be at the PAS in a couple of weeks, you can see the data. You can actually identify which infants have a low lung trajectory. And you can find out how infants with BPD, for example, have a lower AX or area under the reactance curve and a higher resistance, especially peripheral airways, that is R7 to R19. So you can use lung mechanics to find out, does the infant have obstructive lung disease or do they have restrictive lung disease? And you can also use this to find out, are they responding to medications? For example, you can give them albuterol and see, are they responding to albuterol by having a lower resistance? Or you give them Lasix and you see, are they having a better reactance after you give them Lasix? So you can use it to monitor lung mechanics in response to medications too. So this is Colm Travers last year's PAS, still awaiting publication. But this red line in the middle is when we started Lasix. And the time before that, the x-axis is the time. The time before that is the 5 days before, and the time after that is the next 5 days. So you can see what happens to desaturation, that's on the top, and the bottom is bradycardia. So you can see that once you start Lasix, the amount of desaturations decrease, whether you're defining it as less than 85, less than 80, less than 85 for more than 10 seconds, and so forth. And the amount of bradycardia also seems to decrease. So this is a kind of physiologic parameter that we can look at and see if the medication is working. So this is Lasix. This is caffeine after we stop it. Now, many of us stop caffeine when the infant doesn't have any clinical apnea for a few days, generally around 34 weeks postmenstrual age. But then what happens after you stop it? So we looked at our data, and this is not looking at clinical apnea or bradycardia counts, but actually looking at the cardiorespiratory data monitoring. But the red line in the middle is where you stopped caffeine. And the x-axis is the 14 days before to the 14 days after we stop. So you can see that the number of desats starts increasing. And by about 5 days after you stop, it's peaked again. Then it slowly starts coming down. So you can definitely see a change in the desaturation frequency after you stop caffeine. And the bottom graph is looking at what happens to bradycardia. So before you stop it, you can see a reduction in bradycardia. But then once you stop caffeine, it goes back up and then slowly comes down again. So you can see the effects of different medications, not just on lung mechanics, but you can also see it in the cardiorespiratory data. Now, in the last 5-10 minutes, I'm just going to briefly go over pulmonary hypertension in the setting of BPD. So this is not anything that's new. I mean, back in the 1970s, this is Northwest group. They showed that there is extensive vascular remodeling, and 6 of the 21 infants who died of BPD had cor pulmonale. So BPD with pulmonary hypertension has been known since the beginning of the definition. And if you look at what the incidence of BPD with pulmonary hypertension is, so it's very low with mild BPD, but then as you keep increasing the severity of BPD, with severe BPD, it's about 40%. So with severe BPD, about almost half the infants would have some amount of pulmonary hypertension. This was one of the very first prospective cohort studies done from UAB back in 2012, where we screened all infants who were extremely preterm with echocardiogram starting at 4 to 6 weeks of age and then every month thereafter. And we found that there were some infants who had early pulmonary hypertension, even at a month of age, and half of them had persistent pulmonary hypertension at discharge. Some of them had pulmonary hypertension later on. and many of them continue to persist to discharge. So pulmonary hypertension is something that's reasonably common, and it often persists to discharge. And the risk factors for that: lower birth weight, being growth restricted is a high risk factor, and needing more oxygen or being on mechanical ventilation at 4 weeks of age. So being smaller and sicker basically is a high risk factor. And obviously, we treat these infants with multiple medications: oxygen alone, nitric oxide, sildenafil, bosentan, and now we are using more remodeling, that's treprostinil. There are some infants who get Adempas as riociguat, but basically there is very little data or evidence to show which drug is better and which agent should be continued for longer. There are other studies by Peter Murani and others which show that some of these infants have very early pulmonary hypertension starting at 7 days of age, and that's a risk factor for late pulmonary hypertension and BPD. And at about 36 weeks post-menstrual age, depending on the study you look at, it's between 14 and 20%. So between 1 in 6 to 1 in 5 infants will have pulmonary hypertension. And what's the criteria used for that? It could either be a bidirectional or right to left PDA shunt, or ASD shunt, or a VSD shunt, or a right ventricular systolic pressure more than 40, or ratio to systemic blood pressure. But septal flattening seems to be one of the most sensitive features. So septal flattening, if you see it, you need to strongly suspect pH. What are neonatologists doing?
So I've let Ambal know he's frozen again, and hopefully this is the last time.
I'm back.
Thank you. That was fast.
Yeah, I think I'm getting better at this. I'm not really sure why it keeps kicking me off, but let's keep going. I don't have too much more. So there's a lot of variation between different centers and how frequently they're screening. But as I mentioned earlier, regardless of how frequently screened, overall prevalence is about 14%. So pathogenesis and cardiovascular anomalies. This is a normal lung on the left, and on the right is a BPD lung. You can see there are big saccules, there's a lot of alveolar damage, but you can see the blood vessels are also thick, so there is vascular thickening. And it used to be thought that there was a reduction in...
I'm so sorry, Ambal. I just sent you a message that we can't see your presentation anymore.
Oh my goodness.
Yeah.
It says I'm still sharing. Well, let me stop.
Yeah.
Okay, let's see if I can go to this. Okay. Can you see it now?
Not quite. I still have you on my screen.
No, no, I don't see it.
Yeah, if anybody else sees something differently, please let us know, but I still see a frozen Ambal.
Uh-oh. It says I'm sharing my screen.
You're sharing your screen. Okay, let me see here.
I'd have to
Stop
stop
sharing.
and start, yeah.
Yeah.
Okay, let me share again.
Okay.
Okay. Are you seeing now?
You know, I don't. I still see the same one. So let me see here. It might be
Okay.
something you might need to go
Yeah.
off and come on.
Yeah,
Is
let
that-
me leave and get back on.
Okay, super. Thanks.
Okay,
Yep, there you are.
here I am. Let me see if I can. Oh, wait, let me open up the file again and proceed to the okay. Let me see.
So we last saw the survey results from Gabriel's paper.
Oh, okay. So, can you see this now?
Yep, I think we're perhaps one previous to this was the survey regarding BPD and pH.
Yeah, I think probably from this, yeah, but that's fine. I'll move on. So basically, you can see that there is small vessel thickening in BPD. And it used to be thought that the small blood vessels really did not develop, but that's not true. It's not a deficiency of small vessels. It's just that they are dysmorphic. So there are different growth factors. So you have small vessels, except that they don't grow normally. There is a different set of growth factors that are involved. And Steve Abman and others from Colorado have shown that there's actually what you call intrapulmonary arteriovenous anastomosis. So they're like small shunts which go from the pulmonary artery to the pulmonary vein directly. So you're basically bypassing the alveolus, and it's an intrapulmonary shunt. So these intrapulmonary shunts are another reason why you have hypoxemia and pulmonary hypertension. It's not just the fact that you have atelectasis, but these intrapulmonary shunts which are shunting blood next to the alveolus. And if you do CT angio or if you do cardiac cath, you'll find a large number of these infants have other anomalies, aortopulmonary collaterals, pulmonary vein stenosis, large ASDs, which are really hard to make out on just echocardiogram, or a PDA which is more significant than you would think by echocardiogram. So it is suggested that if you start them on treatment and they're not responding well, we need to do a cardiac cath or a CT angio to identify these anomalies better, because these are things which you can fix. So diagnosis is usually based on echocardiography, but you often need a cardiac cath. Biomarkers, like I mentioned, we often use BNP. Other people have used ADMA or endostatin, but that's more for research. And during cardiac cath, you can look for vasoreactivity testing, which actually is a good prognostic indicator. If they're still vasoreactive, then it's a good prognostic indicator. So potential approaches: early identification by echo screening, and then treatment. Again, we are not sure how we should be treating them, but ideally keeping their oxygen saturation target slightly higher, maybe 92 to 96, and early use of sildenafil or a vasodilator is considered to help. We do need large randomized trials in this population. So Sam Gentle, who's one of our faculty, he's done some recent work on this, looking at BPD-associated pulmonary hypertension. And he has shown that both the presence of a PDA as well as intermittent hypoxemia are strongly associated with pulmonary hypertension in extremely preterm infants. So this is actually looking at intermittent hypoxemia. So the blue line is the infant's BPD, and the red line is BPD pulmonary hypertension. And the y-axis is the number of events per day of intermittent hypoxemia, while the x-axis is the duration. So you can see these two crossover. So what it's telling us is the infants with just BPD, they have more episodes but shorter episodes, whereas the ones with pulmonary hypertension, they have fewer episodes but longer episodes. So if you have long episodes, that's more likely to be associated with pulmonary hypertension. And that's something you can see clinically too. So the infant on the upper panel, you can see these brief episodes of desaturation, whereas the infant below, you can see it's a wider desats. Basically, if you look at the trend of the pulse oximetry, you can see that those things almost look like a wide QRS. it's a wider dip. And those wider dips are actually the more prolonged episodes of hypoxemia. And that we think is more a marker of pulmonary hypertension. And we also noticed that a presence and longer duration of a PDA is associated with BPD-PH. I mean, currently, most people don't treat a PDA that aggressively as much as we used to treat them 10 or 15 years ago, because all the trials, the Benedictus, the PDA Tolerate, the Baby Oscar, all of them have shown that actually there is no benefit to treating a PDA early on. But this study suggests that perhaps there is a role for treating a PDA at a later time point. So this is showing the probability of death of BPD-PH, and x-axis is the months of PDA exposure. So the longer you have a PDA exposure, the higher a probability of death or BPD-PH. So again, suggesting that perhaps it's not early closure we should be looking at, maybe late closure is something we should definitely consider. So in conclusion, multiple biomarkers are there: genomic, transcriptomic, proteomic, microbiomic, metabolomic, lung mechanics, mitochondrial function, and so forth. So they can be used to predict BPD or bad respiratory outcomes soon after birth, or actually at the time of birth. You can predict which infants are going to develop BPD or pulmonary hypertension soon after birth. But it's also important to know that these can also be used to observe response to treatments. So for example, if you can measure lung mechanics, if you have an intubated patient, it's easier because you can measure compliance, you can look at resistance, you can actually see are they responding to albuterol, or if you give them Lasix, are they getting better? And you can use it to personalize treatment. So you don't want to be giving steroids to everyone just because they have BPD, but actually look at the lung physiology, identify, are they having intermittent hypoxemia? Are they having prolonged IH? Do they have pulmonary hypertension? Do they have tracheomalacia? It's a good idea to look at lung physiology and personalized treatment. And hopefully some of these studies can also be setting the stage for randomized trials in the near future. Okay, I think I'm finished. So
that's amazing. With
Yeah.
all the back and forth, we still have quite a bit of time for questions.
Yeah, I'm not sure Microsoft Teams doesn't like me usually.
Well,
Well,
maybe,
yeah.
well, maybe you're just getting to know each other.
Yeah. Mhm.
So just a quick clarification question on that slide with the regarding the thyroid hormone. The W and the B columns.
Oh, those are white infants and black infants.
I see. Okay.
Yeah, we
And-
looked at them separately because it seems like there is a bit of a difference.
Ah,
Yeah, I can just show that briefly. So yeah, here is the one. Yeah, if you can see it, yeah, white infants and black infants. Yeah, especially at the first panel is I think at day 1 to 3, and the next two are day 7 to 10 and day 28. So especially day 1 to 3 for black infants, you see a big difference, but not for the white infants.
not so much. Okay.
Yeah.
Interesting. And we're open for questions. So either turn on your camera and ask, or like Dr. Bott here. Dr. Bott, please go ahead, or use the chat.
Well, I think an excellent presentation, Dr. Ambal.
Thank you.
I think my question is, I think we have so many definitions of BPD.
Mhm.
We have got a Vance for a long time. We have got a Jensen's now. We have got the Canadian definition. There might be some European definitions. My question is there any progress in consensus of the BPD definitions? You know more than probably many other people.
Yeah, I think most people are now coming to start using the Jensen staging, especially for clinical trials, because that's the one which seems to be more associated with longer term outcomes. The problem with, I think, the Jensen staging is that it's again a definition based on treatment. We are not really quantifying the amount of airway disease or the amount of pulmonary hypertension or the amount of abnormality in control of breathing. So right now, I think we are still searching for a good definition. But for the moment, I think people are using the Jensen staging.
So my question is, I think when I say my NICU is a better BPD than some other NICUs, then I think it makes it more difficult.
Yes.
Which definition? So then you have to ask the question, which definition? Is there any international committee or something who is looking at to modify or maybe accept the consensus? Because one study would have a different definition than the other, or they may have 2 or 3 definitions. How you can compare the study from one study to another study?
Yeah, you really can't. I think you don't. I think one really can't compare between studies unless you use exactly the same definitions, or unless you have a large network like the Vermont-Oxford network, where at least, or I think you have your California database where you can at least standardize some of the definitions. So then you can compare.
But they both have the Vaughan's definition, but the Vaughan's is more dependent on oxygen, whereas Jensen does not depend on oxygen at all.
Yeah.
So my question is, I think there has to be some, I don't know. I think you know more than I know.
Yeah, well, I think nobody, I think people know, but they think it's hard to get agreement from everyone concerned as to the best way.
Okay, thank you.
Thank you.
So I wondered if we could revisit the slide on Lasix.
Oh, yes.
Early use.
So, yes.
Do you have any, or could you give us any further guidance on Lasix and or diuretic use in the early phase, and perhaps what phenotypes or endotypes might best be?
Yeah, I think that's a good point. So here, this is just the slide. So I think this is looking at the 5 days before to the 5 days after. So we are basically showing a short-term improvement in oxygenation. Or at least a decrease in intermittent hypoxemia, and we're seeing a decrease in bradycardia. We have also shown, I am not showing you here, but we have also seen improvement in lung mechanics. So the important thing is not all the infants improved in lung mechanics, only some of them improved. So I think the point is not everybody is going to get better with Lasix. So if you have something like this, either cardiorespiratory data or lung mechanics, you can actually see which infants are responding. I think about 1/3 of the infants improve a lot, about 1/3 improve a little bit, and 1/3 don't get better at all. So it varies. So it's not like you can assume that everybody is going to get better. So I think it helps to target treatment to some extent. And again, this is short-term use. We don't know what the long-term effects are.
So it sounds like kind of modifying in real time just what the early response is to this.
Yes, yeah.
So along those lines, is there any new information on guidance on which types or how to figure out which babies would respond best to postnatal steroids? You did mention that not everyone is trying to. Yeah,
so there was a paper by one of our group, Sam Gentle, who actually looked at the hydrocortisone trial in the Neonatal Research Network, and he did a post hoc analysis basically to see, does the response to hydrocortisone depend on how sick you are? Mainly, does the steroid work better in the sicker infants, or does it work in infants who are not so sick? And basically, it didn't make a difference. This magnitude of effect was the same throughout. But having said that, I think you can say that probably we should reserve the use of, say, more potent steroids like dexamethasone to after the first 2 weeks of age, because the first 2 weeks you have a higher rate of complications like perforations and so forth. And you also can determine which infants are at highest risk of developing severe